Hi guys, I'm about to head into my swing shift at the hospital, and these shifts can be like completely insane. So I figured I would review fever workup in the hospital so that maybe I can be prepared. We often see this cross-covering hospital patients at night. So anyway, the first step, you have to define the fever. First, is it a true fever? Temperature above 100.9 degrees Fahrenheit consists of a true fever. And then you have to look at the fever pattern. If it's a continuous fever staying high, this points to something like pneumonia, or a cytokine storm from lung infection keeps temperature elevated. What about an intermittent fever, which is like spiking and dropping? This might suggest malaria tied to parasite bursts in red blood cells. If it's a remittent fever where it goes up and down but it's never normal, this could be typhoid fever driven by bacterial toxins. What about a relapsing fever? This is days of normalcy and then fever. This is something like brucellosis, where bacteria hide in immune cells. You can also rule out mimics like heat stroke, where the body's cooling system failed, or even neuroleptic malignant syndrome from dopamine blocking drugs causing muscle rigidity. Step 2 is getting a really good history. You have to ask the right questions. Has the patient traveled recently? Think malaria or dengue. Are they immunocompromised, maybe from HIV or medications like biologics? Consider opportunistic infections like pneumocystis. Any prosthetic valves or central lines, that raises concern for endocarditis. If they've had recent surgery, surgical site infections often spike around post-op day 5. And then some medications, like certain antibiotics, can also trigger a drug fever. So the history is incredibly important. Let's talk about endocarditis. This is like weeks of low-grade fever and fatigue. The pathophysiology behind this is that bacteria, like Streptococcus, for example, stick to damaged heart valves, forming vegetations that shed emboli and trigger immune complexes. And then what about tuberculosis? Night sweats and afternoon fevers are common. Why does this happen? Well, granulomas form to contain the bacteria. They then release tumor necrosis factor alpha, driving the fever. This is especially common when cortisol dips at night, which is why they get night sweats. And then what about pneumonia? This is a high spiking fever with chills. Bacteria like pneumococcus, they invade lung tissue, triggering interleukin-1 and interleukin-6 release, and this will usually be a sustained high fever. The next step is you're going to want to do a physical exam. Obviously, if they have a heart murmur plus splinter hemorrhages under the nails, suspect endocarditis from septic emboli. If they have lung findings like crackles or dullness to percussion, that's pneumonia. If they have enlarged lymph nodes, especially supraclavicular, that could be tuberculosis or even lymphoma. And then also look for skin findings. Petechiae suggests endocarditis. A fleeting rash might point to rheumatoid fever. And then the next step is going to be labs and imaging. You're going to want to start with the basics, CBC with differential, look for a left shift in bacterial infections or eosinophilia in parasitic infection. You're going to want to get blood cultures, at least 2 sets before antibiotics, and then check a metabolic panel for liver or kidney clues, and also inflammatory markers like CRP. Procalcitonin above 0.5 often points to a bacterial cause of the fever. And you can also check ferritin levels. Over 100 might hint at Still's disease, or macrophages go into overdrive. Tuberculosis, you're going to want to order a quantiferon. And for imaging, chest x-rays can catch pneumonia or tuberculosis. CT scans of the chest, abdomen, and pelvis can find abscesses. And for endocarditis, start with a transthoracic echocardiogram. But if you don't see anything and your suspicion is still really high, you're going to want a TEE, which is done by cardiology. And then also, PET scans are great for malignancy if you're really worried or you're stumped. And so we're going to dive in a little bit into fever types and their pathophysiology. So infectious fevers, they're most common. Bacteria or viruses trigger immune receptors, activating pathways that release cytokines. like interleukin 1 and tumor necrosis factor alpha. These reset the brain's thermostat via prostaglandin E2. Examples: spiking fevers and abscesses from pus building up, hectic fevers and endocarditis from vegetation shedding, or night sweats and tuberculosis from circadian rhythm shifts. And then next is malignant fevers. Think lymphoma, kidney cancer. Tumor cells secrete interleukin 6, or paraneoplastic syndromes drive fever. Hodgkin's lymphoma can cause relapsing Pell-Epstein fevers tied to lymph node cycling. Then there's also autoimmune fevers. These are seen in like lupus or Still's disease. Immune complexes or autoantibodies trigger complement activation, unleashing a cytokine storm, often interleukin 1 driven. You'll see high spiking fevers with evanescent rashes in Still's, or photosensitive rashes in lupus. And then there's also thrombotic fevers. These are less common, but they're seen in like pulmonary embolism or malignancy-related blood clots. Clots damage blood vessels, activating platelets and thrombin, which release interleukin 6. These are usually like lower grade fevers, and people often be like short of breath, especially if they have a pulmonary embolism. The next is basically to match the fever pattern to the most likely diagnosis. If you're suspecting endocarditis, use Duke's criteria. You're going to get blood cultures and an echo. If you're worried about tuberculosis, you're going to get an acid bacilli smear or sputum culture. Pneumonia, you're going to do a sputum culture, chest imaging. But if it's not infectious, you want a biopsy for malignancy. And then the step 7 is management. If the patient is septic, obviously put them on broad spectrum antibiotics. But if they're stable, you can kind of dig in deeper and figure out what's going on. You're going to want to reassess daily. If you are completely stumped and you have no idea what's going on and the patient keeps having fevers, it might be time to call infectious disease.